Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time we are wrapping up the TCT 2024 meeting. I'm Nicolas from Mieghem, and as always together with Joost, Daemen, my good friend and colleague. Joost, we are a little bit later than we are used to with the wrap-up because of holidays and so on. But here we go, a lot to talk about, some very interesting and remarkable results. Others not so remarkable. Where do we start?
Absolutely. So very nice TCT meeting, I have to say. Well attended, good vibe, and a lot of studies. As you will hear from us today. So what we want to do is start with the trials within the coronary space. And the one that really stood out, at least one of the ones that really stood out, was the ECLIPSE trial. So ECLIPSE, as mentioned in our preview, a large multi-center randomized controlled trial in patients with angiographically heavily calcified lesions that were randomized 1-to-1 to either orbital atherectomy or standard non-compliant balloons to assess a primary endpoint of minimal stent area and target vessel failure at 1 year. So interesting, 2,000 patients were randomized 1-to-1. Within a lot of sites in the US, 105 sites in total, that eventually led to an average of 3 patients per site per year over an average period of 6 years. So that tells you maybe something about the type of patient that was enrolled. Conversely, all the angiograms were reviewed by the core lab, and apparently the vast majority of cases, over 90%, really was confirmed to have significant calcification based on the angio. Also interesting, orbital atherectomy led to more contrast and longer procedures. 62% of the cases were treated with intravascular imaging, so that was something that was of interest, but obviously partly due to the pre-specified OCT cohort that finally enrolled 680 patients for the primary or co-primary endpoint of minimal stent area. We alluded a little bit to the likelihood of crossovers within this trial, but that appeared to be less than 5%. So with that, both strategies seem to be feasible in the vast majority of the cases. Orbital atherectomy at the end was very safe, very little to no meaningful complications. But then to start in terms of primary endpoints, the minimal stent area completely identical between both cohorts. So I anticipated maybe a minor difference, but that in the studied patient population appeared not the case.
But recall, I did not.
You did not, correct. But the point obviously is that again, this is all about patient classification and selection actually.
Yes.
Clinical endpoint, similar story, overlapping events curves. So actually basically not showing any benefit at all for an orbital atherectomy guided PCI as a, let's say, first go-to strategy in patients with angiographically heavy calcification that were deemed to be candidates for both ballooning as well as atherectomy, attested by the fact that the crossovers in the NC balloon arm was less than 5%. So yeah, a negative study. To me, not sure what we learned here. I think the 2 takeaways: 1, no liberal use of orbital atherectomy should be advocated. And second, in the patients with really true severe calcifications in which the balloon would not cross, on which you angiographically already have strong arguments that a balloon will not cross. Yeah, in those cases, we simply don't know.
Well, I think we do, because those patients were not part of this trial. So I think
Correct.
This was a highly selected set of patients. Yeah. Also the low number of patient enrollments per year per site also attests to that. Also when we spoke to the PIs, to RJ Kurteneda, was also what we heard back. At the same time, I think one of the important takeaways is there is no point in an all-comer kind of treatment of calcium. Right, and you will only use atherectomy in selected set of patients, and there is no point in comparing this with ballooning. This is a different, totally different algorithm, and it's an algorithm anticipate that the balloon is not going to cross. Well, those patients were not studied. And then there is also, I think, one of the important features of this trial, which is the invasive imaging, 60%. Also, RJ emphasized that is a very high number, higher than in most sites in the world, practically. Not so in Rotterdam, for instance. We are definitely above that figure, and that makes total sense because you need to interpret the calcium to determine also the proper strategy. So I think it was a good trial because it's a wake-up call. There is no point in comparing atherectomy with ballooning. There's just no point.
That said, in terms of imaging, what I forgot to mention, that was actually something Ajay presented during the presentation, that in cases that actually were performed with OCT or imaging in general, but mostly OCT versus angio guidance, event rates were half, approximately half as those compared to the cases that were performed without imaging. So again, a call to have a low threshold to use imaging and perhaps be a bit more careful by selecting your cases for orbital atherectomy. A second trial that raised a lot of interest, so to say, and also somewhat surprising findings was the FAVOR-3 EU trial. So as mentioned in our preview as well, a first large-scale European outcome trial using angio-based physiology, in this case the QFR algorithm of Metis, to guide coronary revascularization in a series of 2,000 patients that presented either with stable or unstable coronary artery disease for intermediate coronary artery lesions in 35 sites of Europe. So basically a one-to-one randomized trial in which the primary endpoint was a patient composite of all-cause death, NEMI or unplanned revasc. And then what appeared in the results of the study, that the procedure time, contrast use, etc., are exactly identical between angio-guided versus FFR-guided versus QFR-guided revascularization. However, fluoro time was a bit lower in the QFR arm. But perhaps more interestingly is that a QFR-guided approach, as compared to FFR, led to an absolute increase of about 9% in revascularizations. Particularly driven by more revascularizations in the left circumflex. But then the primary endpoint, so this MACE rate appeared to be 6.7% in the QFR arm, so that was exactly the figure that the investigators anticipated in their sample size calculation, but only 4.2 in the FFR arm. So that means the trial did not meet its preset non-inferiority criterion of 3.5%, with this absolute difference work that has been done throughout the world with QFR, suggesting this to be a very accurate and valuable alternative to conventional pressure wire-based physiology. Based on the FAVOR-3 China trial, which showed superior outcomes with QFR versus angio-guided PCI in a similar population, QFR even got a guideline recommendation, 2A and 1B in the guidelines as of today in the most recent CCS guidelines. So I think this is an eye-opener, or maybe a wake-up call for all of us who are really enthusiastic about all these new tools and techniques. Proper data is needed in order to test the validity of these strategies in routine practice. That said, I don't want to be too negative. I think it's great that we finally have a European trial. There are 6 other trials on the way, because obviously the question remains, why is it non-inferior? What was it that actually drove the difference?
It was not non-inferior.
It was not non-inferior. So what was it that drove the difference between both treatment arms? I mean, if you have 9% more revascularization, it's somewhat unlikely to me that resulted in an absolute difference in hard clinical endpoint, or at least clinical endpoints of 2.5%. That's relatively seen a bit odd. Plus, I mean, even the increased treatment rate in the circumflex did at the end appear not to drive the outcome, because most events were related to LAD lesions. So a lot of unknowns and a lot of questions. Niels Holm promised me that the core lab was working hard to get also the core lab QFR findings, because that is obviously number 2 in the equation. It could be that something works very well by trained investigators offline in a core lab, but in clinical practice, is perhaps somewhat different throughout the day in a huge cohort of investigators. So more to come. Phase 3 finished enrollment. The CathWorks trial is on the way. Pulse Medical is working on several new and larger trials. So we need to see what comes out. But at least for QFR, a big bummer, so to say.
Well, but definitely not the end of angio-based physio or coronary physiology. But I agree with you. We have to keep the eye on the ball here and make sure that we also are collecting the scientific background to put this in our practice.
And it may be that not all indices are the same, right? I mean, a lot of correlation work has been done on inter-observed variability, etc. And that also for QFR and a QREP trial was actually not too positive, whereas for the other indices that seems to be a bit more positive. But again, we have to await the outcome of the future.
But we didn't see this coming, did we?
Absolutely not. At least I did not.
No, me neither. Flash
trial, I'm going to be a little bit shorter on this one. Jungmann presented this trial, a Korean trial that assessed the non-inferiority of an AIQCA-based revascularization algorithm versus IVUS in relatively low-risk patients with coronary artery disease. Trial was designed to assess non-inferiority of AI-based QCA in a series of 400 patients with the primary endpoint of being minimal stent area. And that appeared to be the case. So minimal stent area, about 6.2%, not statistically different between both arms, which made the investigators actually conclude that in settings with less resources, a AI-QCA-based algorithm could be a valuable alternative to IVUS-guided PCI in patients with less complex disease.
But why only then in the context of a setting with less resources? Why not also as a replacement?
Yeah, that's a good question. It could be tested as a replacement in larger and more complex cases as well. That is something that may happen in the future. But I think when I started to think a little bit better about the design of the trial, I mean, there is now this clear Class 1A recommendation to use imaging in patients with complex lesions. So that is the gold standard. This is in which the treatment is obviously also based on optimization in peri and post-procedural setting, etc. That's obviously not what AI-based QCA does. It's mainly focused on stent selection pre-procedure, with an algorithm, by the way, that was a bit more aggressive in terms of upsizing your stents with about 0.25. Whereas that was also present at least that's what the investigator showed, that eventually the stent diameter was somewhat larger in the AI-QCA arm as compared to the IVUS arm, which obviously positively impacted the final minimal stent area. But maybe this is something to study in the near future. Conversely, also in light of FAVOR 3, I think we need to be very careful by putting too much emphasis on these AI-based algorithms. It is promising, but it needs to be properly studied. Yeah. Good. The DCB bifurcation trial. So this was a Chinese trial, randomized controlled trial, assessing the superiority of side branch DCB treatment after provisional drug-eluting stent treatment in patients with true coronary bifurcations. So 784 patients that were randomized 1-to-1 to either DCB of the side branch or standard non-compliant balloons after provisional stenting of vessels that finally ended up with a side branch with disease, more than 70% diameter stenosis after main vessel stenting. Primary endpoint was MACE, including any death, periprocedural MI, TVR, or stroke at 1 year. And that appeared to be the case appeared to occur in 7.2% of the patients in the DCB arm versus 12.5% in the standard arm with the non-compliant balloon. So this difference was significant, showing superiority of the drug-coated balloon. But conversely, when the investigators attempted to explain the difference, that became a little bit more complicated because the difference was primarily driven by somewhat lower rates of target vessel MI, no difference in TLR, and the discrepancy in the time at which the target vessel MI and the TLR occurred. So difficult to explain, so to me at least, a hint into potential benefit of DCBs, but certainly something that needs to be studied further.
This is definitely not the definite trial on DCB in bifurcations. And at the same time, was there any data on type 3 myocardial infarcts?
No, I haven't. It could be. I haven't seen the.
Because you would expect more with the
potential
DCB,
differences.
Yeah.
Yeah, maybe if I don't know why. Because of the inflation time?
Yeah.
It's, 50 seconds, I don't know.
Yeah, and then also what I'm wondering is if you have the provisional stenting approach and you would not eventually convert to a two-stent strategy, I'm not always using a non-compliant balloon.
Me neither.
Food for thought. Food for thought.
Good.
All right, let's go to the structural space.
Yes, early TAVR.
Yeah, early TAVR, hands down, the trial of TCT, at least in my opinion. So Philippe Généreux presented the early TAVR trial and also published in the New England Journal. 900 patients in the US and Canada were randomized 1-to-1 to either an early TAVR with a balloon expandable sapien system or clinical surveillance. The mean age of the patients, 75 years old, 1 in 3 were women. By default, per protocol, ejection fraction had to be normal, STS score was low, less than 2. The maximum velocities of 4.3 meters per second in keeping with severe aortic stenosis. And up to 90% of all the patients had a treadmill, had a stress test up front, just to make sure that these patients truly were asymptomatic. I think what was important is basically the main findings. The primary outcome was a composite of death, stroke, and unplanned cardiovascular hospitalization and a mean follow-up of 3.8 years, while early TAVR turned out to be superior to the clinical surveillance with basically a doubling in the number of unplanned hospitalizations, 20% versus 42%, but no difference in mortality and even a trend in favor of fewer strokes with the early TAVR arm. So now let's zoom in on the clinical surveillance arm. 87% of those patients finally underwent a valve replacement during the trial, which is obviously quite significant and not so unexpected. But the median time to AVR was only 11 months and approximately 50% of the clinical surveillance arm already had their valve replaced within the first year. The median time from symptoms to valve replacement was only 1 month in the clinical surveillance arm. And this basically is one of the key takeaways. Yeah. Clinical surveillance need to be at a very high standard to duplicate the results in the early TAVR trial. And that is a lot, because if you are waiting too long, and we'll get to that in the study later, then obviously you will see more and more events. What also was, I think, impressive is that up to 40% of the patients in the clinical surveillance arm basically had advanced heart failure symptoms the moment they were receiving their valve, which is quite unexpected from my end. But apparently that was the reality in the United States. And also in 1 in 5 of the patients, the ejection fraction had regressed to less than 50% when these clinical surveillance patients were receiving their valve. The KCCQ also had dropped by 14 points at time of conversion, but that is by default because they became symptomatic. So you will see a fall in the KCCQ. But I think the important takeaway is if a patient has asymptomatic severe aortic stenosis, then you really need to start talking about valve replacement with your patient. And some patients will be inclined to proceed with the valve, then there is no point in waiting. Others have more like a watchful waiting approach, and that's also good. So you have a shared decision-making process here, but I think we need to be maybe a little bit more consistent and more meticulous in the way we are doing clinical surveillance. And that means you don't bring these patients back after a year, bring them back after 3 to 6 months, just to make sure that you are ahead of the curve when these patients are becoming symptomatic, because otherwise they will come to the hospital heavily symptomatic with a so-called acute valve syndrome, or they have their ejection fraction below 50%, and then obviously all the risks of the procedure itself will increase. That would be my take of early TAVR. I cannot agree more. Very interesting trial, one of the most important ones of the meeting. Perhaps also maybe the trial with most impact on our clinical practice in terms of what has been presented at this meeting. Well, we have now 3 positive studies in asymptomatic AS. We have 2 surgical trials, smaller trials, and now this one. I think the guidelines need to be modified next time.
Yeah, a couple of comments maybe. So I found it striking, as you mentioned. I mean, you confirmed that the authors confirmed that basically everybody in this trial was truly asymptomatic at the time they went into the trial. And then most patients had their event or their increase in symptoms of valve replacement in the first 60 days, and not only the first year, but in the first 60 days, half of the patients came in with NIA class 3. So that's quite early. Huh? That's something that I find a little bit awkward.
Well, but
I heard people say, this is like fame 3. Mr. Van Mieghem, you have 3 vessel disease. Yes, that's a bad thing. But you know what? We don't have evidence. We're not going to treat you. We'll see you back if you have symptoms. Then obviously these patients come back and have symptoms.
I agree
but conversely, that's clinical practice, right? I mean, we tell them what the diagnosis is. And that is no different with aortic valve stenosis as compared to coronary artery disease. Second, stroke difference started to emerge after 2 years in which the numbers at risk really decreased. And the third thing is that what is very interesting, TAVI within 1 month in basically everybody. And there were a lot of people, we chatted obviously with a lot of people at the meeting, and many sites have waiting lists for 6 to 9 months now for TAVI. And that makes you think that there is no point in actually even calling back these patients. In a lot of cases, you better just plan them and put them on the waiting list, specifically in light of this trial.
And zero signal of harm, eh?
Zero. Yep, absolutely.
So
important one.
Yeah, it attests to how TAVI or TAVR has matured now to basically the go-to treatment in patients with aortic stenosis. Now let's go to EVOLVE. EVOLVE was a little bit more complex trial. There was a trial in Scotland. This trial was ended because of slow recruitment. 427 patients were screened and only 224 patients were eventually enrolled in the trial. The mean age, 73 years old, 1.25 to a third were women. The Vmax, again, 4.3 meters per second, so definitely severe aortic stenosis, but all the patients also had an increase in troponin. So basically a highly selected set of patients with so-called asymptomatic aortic stenosis. And also there was not this drastic treadmill testing up front. So I think we have to interpret this trial a little bit differently, but at the same time, all the patients received a MRI to look for mid-wall fibrosis. So all the patients by default had mid-wall fibrosis. So that is basically a patient set at the higher risk for events, especially if you also combine it with positive troponins. Turns out that there was no significant difference in the primary endpoint at 1 year between the two treatment strategies. The primary endpoint was a composite of all-cause mortality or unplanned aortic stenosis-related hospitalization. The follow-up was up to 2.7 years. So we're talking about 18% of events, the event rate in the treatment arm versus 23% in the clinical surveillance arm. No difference in mortality. And they did also see a 60% reduction in unplanned hospitalizations for aortic valve disease-related matters. My interpretation is the added value of MRI once patients already have troponin rise, although they are still symptomatic, then you cannot ignore the early TAVR trial. These patients need to get their workup for a valve replacement. Also of note, the clinical surveillance was also different in EVOLVE as compared to early TAVR. It took months once the patients became symptomatic to receive a valve, and also in the treatment arm, it also took quite some time before they got their treatment. Before they got their treatment, but maybe it resembles a little bit more everyday practice in most geographies. So there is, I think it's a very valuable trial, but you cannot interpret EVOLVE without early TAVR. And I think then down the line, I think the main message is, let's take asymptomatic severe AS very seriously, and let's start working these patients up for a valve replacement.
Yeah, I cannot not agree more, and nothing to add to this one.
There you go. So more upstream TAVR, and this time in moderate aortic stenosis, I had the privilege to present for the first time the results of the TAVR-UNLOAD randomized controlled study in patients with HFrEF, heart failure and reduced ejection fraction, on guideline-directed medical therapy with concomitant moderate aortic stenosis. A difficult trial to run. We ended up enrolling 178 patients, and unfortunately, we were forced to interrupt enrollments by the end of 2022 because of slow enrollments. The slow enrollments were there because of COVID, obviously. Also, this phenotype of patients is not so easy to identify, but also not so easy to get them referred to a tertiary care institution. And then there was also the PROGRESS randomized controlled trial that initiated in 2021, and that obviously drained a lot of patients away from TAVR-UNLOAD. That said, 178 patients, the mean age 77 years old, 1 in 5 women, and these patients really had heart failure with reduced ejection fraction. The mean ejection fraction was 39%. The left ventricular end diastolic diameter was 6.6 centimeters, so dilated ventricles. And those patients were randomized 1-to-1 to the balloon expandable TAVI with a SAPIEN system or clinical surveillance. And the clinical surveillance basically was focusing on only valve replacement when the valve was degenerating from moderate to severe aortic stenosis, so only then. Well, long story short, the primary endpoint, which was a hierarchical occurrence of mortality, stroke, hospitalizations, or change in quality of life, was no different between the two strategies at longest follow-up. But if we would only focus at 1 year, which was the original endpoint of the trial, then it was significantly in favor of preemptive TAVI. That tells us that things are changing in the clinical surveillance arm, and that doesn't come as a surprise. 40% of the patients required a valve because of progression to severe aortic stenosis, and that obviously will affect the outcomes, the clinical outcomes of those patients. But what was important to realize is that the clinical surveillance was also very stringent. So patients were seen at 6 months intervals. So when we would see a progression from moderate to severe, 1 in 5 already progressed within the first year, well then all of a sudden there was a guideline indication for a valve replacement. Yep. Changes in quality of life, that was significantly in favor of for a preemptive TAVR or TAVI procedure or strategy, where you could see immediately an improvement with more than 12 points in the KCCQ in the TAVR arm. And in the clinical surveillance arm, you basically see a gradual increase in the quality of life, obviously because those patients were receiving a TAVI because of disease progression. And an interesting finding was that at 3 years, there were no more patients alive in the clinical surveillance arm without a TAVR. So they all had progressed to severe AS and received a TAVR, or they had died. I think this is an important study because it tells us that clinical surveillance is very important in these patients. So you should not wait for another year to see these patients back again and then reassess their aortic stenosis, because they might have an expedited progression of the aortic stenosis. But we also have to acknowledge that basically you will not change the hard clinical endpoints with a preemptive TAVR treatment.
Yeah, and that means that the guidelines as they are today
not so bad.
Still remain valid.
Yeah, not so bad. So obviously we are also looking at other phenotypes of patients with moderate aortic stenosis. In comes this paradigm of cardiac damage. Those patients, regardless of ejection fraction, would qualify for a valve replacement if there is a signal of cardiac damage, and that can be on the left ventricular side, for instance, LVH or a global longitudinal strain that is impaired. It can be an issue relative to the mitral valve or to the left atrium or to the RV or to the pulmonary circulation. So much more flexible in terms of patient enrollments. That also explains why PROGRESS completed its enrollment of more than 600 patients within 2 years, but we'll have to wait for the results of PROGRESS until 2026.
Yep.
At the same time, there's also the TAVR Expand 2 trial that is still ongoing, and that is looking at the evolute valve in moderate aortic stenosis, but obviously those data are expected even further down into the future.
Yep. PEERLESS.
So PEERLESS, we change gears. We go now to the treatment of pulmonary embolisms. PEERLESS was a randomized controlled trial, randomizing patients to the Inari FlowTriever, so this large bore mechanical thrombectomy, or treatment with echo-guided thrombolysis. 1,200 patients were randomized 1-to-1. So quite a big number of patients. And then they had a hierarchical composite endpoint with, I think, 5 or 6 items in that composite endpoint. I think the main takeaway is that the win ratio in favor of the mechanical thrombectomy was huge. It was 5, which is huge. And it was primarily based on faster improvements of the patients, less deteriorations, also shorter hospital stay, shorter need for ICU or no need for ICU, and also faster improvements of RV function. And there was no penalty of major or intracranial bleedings in the mechanical thrombectomy arm. So in my opinion, an important study, because we were looking at patients at intermediate risk pulmonary embolisms. I think what we were missing was an arm of patients that were only receiving anticoagulant therapy rather than thrombolysis. But okay, I think it is an important study, and it also fits with contemporary practice. You see a growing uptake of mechanical thrombectomy. Intuitively, it makes a lot of sense. Now we have a randomized study to back this up.
Yeah, and I think that's tremendously important. I mean, 1,200 patients with massive thrombectomies. This is the largest study on the topic as of today. It shows us that a novel generation of technologies with aspiration thrombectomy simply, if any, better as compared to, in this case, catheter-directed thrombolysis, whether it's also better as compared to standard anticoagulation and perhaps thrombolysis will be studied in the ongoing PEERLESS 2 trial that is currently finishing enrollment. So something to follow in the near future, but definitely very promising technology that will have its pick up in clinical practice.
Yeah. CLEAR-IE is another interesting study related to large bore mechanical thrombectomy. And this study was focusing on patients with infective right-sided endocarditis, a very interesting set of patients. They managed, so this was a US-based initiative, I think from the Mayo Clinic, where 256 patients were identified. And these were very sick patients. The mean age of the patient was only 43 years old, and as expected, up to 50% of the patients were IV drug users. Most often, the vegetation on the tricuspid valve was there with some degree of tricuspid regurgitation. And these patients, they presented in sepsis, with hypoxemia, and so on. Predominantly, the AngioVac, which is more a steering catheter, was used, but also the FlowTriever was applied in these patients with an access through a femoral or jugular vein. And I think it was very important to see that there was a culture clearance in 92% of the patients. So these patients had infective endocarditis, positive blood cultures, while they became negative in 92%, which is important. And procedural success, which was defined as removal of at least 70% of the vegetation or a reduction of the vegetation to less than 1 centimeter in diameter, was achieved in 90% of the cases. And I think this is very impressive. And from time to time, we also use it in our practice. So I have some anecdotal experience, and it does work. I think, bear in mind, again, very sick patients, 10% in hospital mortality, 15% of the patients regressed to respiratory failure, and worsening of the R occurred in 15%. That said, we are talking about patients that were probably turned down for surgery, and we all know the risk of open heart surgery for right-sided valve issues, especially in the context of endocarditis. So I think this is a very promising application of this technique.
Yeah, absolutely.
Talking about tricuspid regurgitation, we had the TRISCEND 2, and this was an important randomized controlled study evaluating TTVR, so transcatheter tricuspid valve replacement with the EVOQUE system in patients with severe tricuspid regurgitation. 400 patients were randomized coming from the US and Germany. The mean age was 79 years old. The majority of patients were women, and 40% had already a pacemaker in place. The mean pulmonary pressures were 38 millimeters of mercury, so they were kind of elevated, and the patients were all symptomatic. the primary endpoint was again a composite hierarchical endpoint, including death and the need for an RVAD implantation, but also heart failure hospitalizations and changes in functional quality of life or New York Heart functional class. The win ratio in favor of TTVR was 2.2, which was significant, but it came at a cost of more severe bleeding, so 15% in the treatment arm versus only 5% of major bleedings in the control arm, and more pacemakers. 17% of the patients required a pacemaker, but if you look at only the patients who did not have a pacemaker at baseline, this number increased to 28%. So I think this is the first trial with a TTVR system in a randomized context, comparing it to standard of care. And again, the benefits are driven on functional improvement of these patients. So don't expect major effects on the heart clinical endpoints. So no effect on rehospitalizations, no effects on mortality, but a substantial improvement in quality of life of these patients.
Yeah.
Is this something that we're going to use in our practice, Joost?
Well, you know, I think it's at the end it's a positive trial. Conversely, maybe we hope for a bit more, right? With TEER, we learned that you always are left behind with mild to moderate tricuspid regurgitation, and then we know from these trials that at the end it doesn't make any big difference in terms of heart clinical endpoints, but patients do better. And now with a device that virtually eliminates all residual tricuspid regurgitation, we hope that maybe would be the tipping point towards getting better outcomes as well in terms of more heart clinical endpoints. Well, that did not appear the case. So with that in mind, I think it could become a valuable option for patients with massive TR, in which you think there is a low likelihood that you will get proper TR reduction. And these patients at the end do better. And I think that is something that is of interest, but should be put into perspective to the type of patient to which this is applied.
Yeah, and as you mentioned, so you really strive for complete elimination of the TR. And how does that then compare to, for instance, a tricuspid TEER? Well, that remains the question, and this might become the subject of a new randomized study. So stay tuned for that in the future. Access TAVI. This was a study from Germany where they looked at a modification in large bore access closure in TAVI from the standard. So typically 2 sutures are being used. Here we are comparing one Pro-style perclose in combination with an angioseal versus 2 percloses. And 454 patients were included. The primary endpoint was any vascular on access site related complication per VARC3. I think the results were quite impressive. So favoring the combination of a ProGlide with an angioseal, 27% complication rate versus more than 50% complication rate in the 2 suture strategy. I must say that we were not so surprised to see a benefit in favor of the perclose in combination with an angioseal, but the number of complications was super high and total, I mean, from a different order as compared to what we saw in MESH, where the 2 suture strategy only had a access site complication rate of 4%. And in choice closure, it was, I think, 12%. Yeah. So this tells you also how important it is to look at how the endpoints were defined. So you cannot just one-to-one compare access TAVI with, for instance, the MESH trial or with choice closure. But I think it's fair to say that if you would have a default or a go-to strategy of 1 perclose with 1 angioseal, you will probably end up with using less closure devices, because 40% of the patients in the control arm with the 2 percloses required an additional closure device. So I think it might become, from a cost-effective point of view, more interesting to combine perclose with 1 angioseal. What does that mean for your practice, Joost?
Yeah, I mean, you know, in the beginning I was quite critical. I mean, I thought, what's the point, right? If you get basically 2 to 4% major vascular complications with the 2 ProGlides, I mean, what is there to win? Well, this trial shows you that there is an alternative. It saves you cost, it saves you money. Exactly, also time. And if you apply it in practice, what you could do is you put your ProGlide in, you still have the wire, you put your 8 French angioseal, and if it's still bleeding, you take it out, you put it on the ProGlide. If that doesn't work, or you have hemostasis with the sheet of the angioseal in, then you usually, I think, are fine, and that makes this a strategy that I think I will more and more start to consider during routine care.
Me too. You know, my major reservation was that if you would start with a strategy of 1 per close with an angioseal, that you would give up your safety wire, but you will only give up your safety wire when you're not happy when the sheet of the 8 French angioseal is not giving you proper hemostasis. If it doesn't, well, okay, then you take out that sheet and you add another suture. So it gives you a little bit more leeway, and you will end up with less closure devices to obtain your hemostasis. The last trial in the structural space was the ALIGN-AR trial. This was obviously focusing on the use of the JenaValve Trilogy valve for patients with severe aortic regurgitation, a prospective registry, 180 patients. The 1-year data were also published this year in The Lancet. At TCT, the 2-year data were presented, and those were of interest because we already know that when using these dedicated AR technologies, you will have somewhat a higher pacemaker rate. Pacemaker rates were 24%, but the 1-year mortality was only 7%, and at 2 years it was 15%. It was still well below the performance goal of 25%. So basically, also the hemodynamic performance and the performance in general of the JenaValve for this indication was excellent. So no patients with more than mild PVL. Valve gradients were superb. So I think very promising results with this technology. And I think the major takeaway of the presentation was also the announcement of the ARTIST randomized controlled trial, where patients with severe symptomatic AR at a higher operative risk will be randomized to either surgery or TAVI with the Trilogy valve. So this definitely is something to look forward to, and this patient is about to start enrollments early 2025.
Yeah, so very promising technology, and it's good to see that the program now really took off, randomized trial on the way. And I have to say we did a number of cases, and it's a nice.
Okay, then we have, I think the last one is in terms for structural, was the COSTAR RCT. This is the randomized study by Thomas Pilgrim, where he looked at the value of colchicine for 30 days in patients after TAVI, and the ambition was that this anti-inflammatory properties of the colchicine would affect the new onset atrial fibrillation or the need for pacemakers based on conduction disorders, acquired conduction disorders. Well, this trial was also prematurely ended because there were more strokes in the colchicine arm, and 5 cases were reported. Probably a play of chance, but it made them stop or interrupt the study. If they looked at their primary endpoint, there was no significant difference between the 2 treatment strategies, so whether or not you use colchicine, but colchicine showed a clear trend in favor of fewer pacemakers. And this is of interest. No effect on new onset atrial fibrillations. I think we'll never know what the colchicine will be in the context of TAVI, because I suspect that we will not get another randomized controlled trial for this.
That is what I was about to say. We were a little bit maybe critical on the hypothesis. Conversely, it's interesting, and there is the pity is there's really a strong trend towards the hypothesis that the investigators searched for, but at the end, this is it's a pity that the trial was stopped prematurely because of something that is, as you say, very likely due to a play of chance. But we'll never know, and I agree that it's unlikely there will be a successor in this series of trials.
And then there was also the ACURATE IDE trial. This was a randomized controlled study comparing the ACURATE Neo2 to the commercially available valves in the United States, 1-to-1 randomization, and it ended up a negative study, meaning that the study did not meet the non-inferiority. And there were several reasons postulated. Mike Reardon suggested that in 20% of the patients in the ACURATE neo2 arm, the frame was not properly expanded, so the use of the valve was not according to the IFU. And that was a post hoc analysis, and I think they are still analyzing the data because the study hasn't been published so far. But it was remarkable because this is the third randomized controlled study with this platform that ends up not reaching its non-inferiority endpoint. Yeah, it is. I must say that I was surprised. I did not expect this. I also don't see in my practice more events or a higher event rate that come to my mind, at least, in patients using the ACURATE valve. But, you know, something needs to be done here. And I think what is required is a positive randomized controlled trial. So I hope that we will see a randomized trial starting soon with this platform, because otherwise it's going to be a tough call. Yeah,
so this was a tough discussion at the TCT, and I think what you said is critical. I mean, if you ask the experts in the field, everybody says, well, you know, this actually is not what we're seeing in clinical practice. But conversely, when all the cases were done within this trial, you could say, okay, the US investigators were more familiar with the Evolute and with the SAPIEN. This was a new platform. Conversely, per procedural outcome was basically identical. All cases were proctored by a Boston proctor. So, I mean, if there was a need based on all the European experience in the 8 years ahead with switching angles, checking expansion, etc., why wasn't that done in this trial? I don't really understand what happened here.
A lot of open ends, and that is why I would urge for another randomized controlled study. And also in sites that are very familiar with using this product, because that obviously there was an imbalance there. So sites were very experienced with the commercially available valves, and they were in their early experience with the ACURATE valve, and they were only enrolling very slowly per site. So
but I think that a subsequent trial is needed, right? I mean, we'll see what the FDA will say about this result, but I fear that they may request more data.
Yeah, it seems inevitable. And let's also end this wrap-up with an unexpected surprise in the coronary space.
So a lot of negative trials, or negative at least, trials that did not meet their primary endpoint. And perhaps one of the most striking ones was also Clear Synergy. So Clear Synergy, please recall, the large randomized controlled trial from Canada, presented by Sanjit Jolly. So 7,000 patients that were randomized within 72 hours after acute MI to get either colchicine versus placebo, with the intention to decrease the primary endpoint of cardiovascular death, MI, stroke, or unplanned revascularization. Basically no difference. Overlapping event curves up until 1 year. The only difference was more diarrhea in the colchicine arm, a little bit what you would have expected, but otherwise, no benefit at all for colchicine. Interesting to note, this trial had a 2x2 factorial design in which patients were randomized to combinations of spironolactone and colchicine in 4 different variants, of course. The colchicine results were presented here at TCT and simultaneously published in the New England. The second arm of the trial, assessing the effect of spironolactone, will be presented at the actually at this time ongoing AHA meeting. So that is still to be expected, but for now, with respect to adding colchicine post-MI, at least in patients, so in all comer series of patients, no reason to do that.
Yeah, but not at least in the short term, following the event, because there are other randomized controlled studies in the context of HFrEF, but also HFpEF that we've seen that MRIs are quite effective in reducing symptoms and improving outcome. That said, we are at the end of the wrap-up of TCT 2024. I hope you enjoyed it. There was a lot of data, a lot of information. We look forward to future meetings.
Thank you for watching. Bye-bye.
Bye.